Hello, welcome to Med One Pager. My name is Benjamin, and today I'm going to be talking about lung cancer. So, when we look at lung cancer is found to be the leading cause of cancer mortality worldwide. And this is not a new thing, but almost everyone knows that tobacco smoking is the major risk factor for developing lung cancer. And when you look at lung cancer, it's going to come in two types. We have the small cell lung cancer, and as the name suggests, the cells that are seen on histology are going to appear small, and we have the non-small cell lung cancer. So the classification, which we have already looked at already, is that we have the small cell lung cancers. These ones are mostly going to come from neuroendocrine cells, or what they call the Kalchitsky cells, and these cells are found all over the lungs. And most of the time, they're going to produce substances like histamine, substances like serotonin, and these ones are going to play various roles, probably influence the bronchial constriction, things like that. Then we have the non-small cell lung cancer, which is epithelial in origin. And because it's epithelial in origin, it's going to affect the epithelium. And we have different kinds of epithelium within the cells. We have the glandular epithelium, then we have the squamous epithelium. So when you look at the glandular epithelium found in the glands, if there is a chain there, we're going to have what we call adenocarcinoma. And the adenocarcinoma of the lungs is going to affect the cells known as the type 2 pneumocytes, which are the cells that produce surfactant, which are also called the Clara cells. And these ones are found and when you look at adenocarcinoma, it's going to affect majorly the periphery of the lungs, towards the edge of the lungs. And we shall see that on a CT. Then, when you look at the squamous cell carcinoma, it's going to be central. It's going to be near the bronchi, the bronchioles, around there, because this is where we have the squamous cell, the squamous epithelium, and it is going to have that central appearance on the scan, and it's going to affect the basal bronchial cells. Then we have the large cell carcinoma. Now the large cell carcinoma is going to come in when we have cells that are cancerous, but they do not actually go on to differentiate and appear like any other cell in the body. They are undifferentiated, and they're just going to be large cell carcinomas, and they're going to have larger opacities on when you look at them on X-ray. So when you look at the epidemiology and the risk factors, small cell lung cancer is going to appear almost exclusively in smokers. And it is too bad that because this is associated with a very, very bad prognosis. Then the non-small cell lung cancer is going to be associated with other things like genes. When we shall look, I'll put for you a list of the genes that are implicated in non-small cell lung cancer on the side. Then we have age, whereby ages that are upward, like 60 and above, are going to be typical. And this is because when you look at this, these people have been exposed to the carcinogens for quite a longer period of time. So it's no surprise that they eventually succumb to the problem. Then we have occupational exposures like asbestos, radon gas, and then silica. And then radon has also been implicated in some texts to be almost the second most common cause after lung cancer. The second most common cause of lung cancer after cigarette smoking. And then when some studies were done, they showed that asbestos exposure on top of cigarette smoking has been implicated as even having a synergistic effect in the causation of lung cancer. And then when it comes to smoking, even secondhand smoke, that is the passive smoking, when you inhale smoke from someone who is smoking, you're going to have an increased risk of developing lung cancer. So when you look at the pathophysiology, what's going to happen is that we're going to have tumor growth, and then a tumor can cause the following. It can either cause a local invasion, it can cause an obstruction, or it can metastasize. And then when we have small cell lung cancer, it has a characteristic of rapid doubling, whereby most cancers take about the non-small cell lung cancer may take around 400 days to double in volume, but the small cell lung cancer may actually double within a short time. When you look at this small cell lung cancer, within a period of like 40 days, the cancer might have already grown, and then it has early dissemination, so it spreads very fast, and it has paraneoplastic syndromes a lot. This is because it comes from neuroendocrine cells, and as you hear the name endocrine, so these cells have capabilities to secrete different hormones, and this is going to cause the paraneoplastic syndrome. And I'll explain paraneoplastic syndrome in this video, so hold on a moment. When we get there, you will understand everything to do with that. So when you compare the small cell lung cancer and the non-small cell lung cancer, when the small cell lung cancer is central, it's composed of small neuroendocrine cells, has rapid growth, early metastasis, and it is orally sensitive to chemo or radiotherapy. And it has sensitivity to chemo and radiotherapy, but it has a poor prognosis with less than a 5% survival and commonly associated with paraneoplastic syndromes. Then when we look at the non-small cell lung cancer, it has larger epithelial cells and has a slower growth. And most of the times can be resected, and I'll show you at the end of this video some of the ways how resection of this cancer can be done. It has a variable prognosis of 15 to 60%, 5-year survival rate. Less frequent, we can have paraneoplastic syndromes. They're not as frequent as you see in small cell lung cancer. Then the patterns of spread is that earlier on, small cell lung cancer is going to spread rapidly, early hematogeneously, and it's going to go to the brain and liver. And sometimes in some management protocols, they advise early irradiation of the brain actually as a prophylaxis when we have small cell lung cancer. Then when we look at non-small cell lung cancer, it is slower and often is going to cause regional symptoms, stay around there. And when we have the adenocarcinoma, it spreads to the brain, the bones, and the liver. And then we have squamous cell carcinoma. Most of the time, it's going to do the local invasion, all the less distant spread. So one thing you should notice that the when you look at this non-small cell lung cancer, the adenocarcinoma is the one that has the highest percentage of is the one that is highly encountered most of the times. And when you compare non-small cell to small cell is less frequent than the non-small cell. So if it comes to the order of the epidemiology, how we find these small cell and non-small cell, non-small cell is going to be the most common type of lung cancer, and the adenocarcinoma is again the most common type of non-small cell lung cancer, followed by the squamous cell, then the large cell at the least. So when you look at the clinical features of lung cancer, we have the local or the respiratory symptoms. These ones are understandable. We are within the chest, we are within the lung. So cough is there, hemoptysis, which is coughing or blood, dyspnea, which is breathlessness, chest pain, and recurrent pneumonias, because sometimes these tumors cause that obstruction. So when we have obstruction, secretions accumulate, organisms are going to accumulate there, and then we end up having a pneumonia, then wheezing and hoarseness. Then we have the regional or the ones due to invasion. And when you look at the chest, things that are nearby, we have the superior vena cava. So if the small cell lung cancer invades the superior vena cava and causes blockage, the tumor compresses on the superior vena cava, all the veins that drain into that are going to become engorged. So the head, when you look at the head, almost all of it exclusively drains into the superior vena cava, plus the upper limb. So this patient is going to have things like flashing of the face, redness. When you look at the retina, they could be having retinal edema. They could be having features of congestion in the head. Then when you look at the pancreas tumor is when the tumor occurs towards the apex of the lung. And when it occurs in the apex of the lung, as you can see on this x-ray, when it occurs in the apex of the lung, we have various things that are passing there. One is that we are near the stellate ganglion, and that is one that provides the sympathetic supply to the eye. So when we have a pressure on the stellate ganglion, we're going to have what we call the Horner's syndrome. And when we have Horner's syndrome, you know the triad. We have anhidrosis, which is no sweating. We have meiosis, and then we have ptosis, which is drooping of the eyelid. Then we have phrenic nerve palsy, because the phrenic nerve also courses. It comes from up and courses through the mediastinum as it goes to innervate the diaphragm. So if we have a phrenic nerve palsy, this patient is going to have some form of breathlessness, or whenever they are going, whenever they are exerting, they're going to have breathlessness. Then we have dysphagia because the esophagus is right also there in the neck. So if we have a tumor that is medial and it compresses on the esophagus, we may have dysphagia, and then we may have pericardial effusion, which is when the tumor infiltrates into the pericardium of the heart, and the pericardial effusion can be detected by the Beck stride. Then we look at metastatic disease. We can have the tumor metastasizing to the brain, and the patient may present with headache, seizures. The tumor may metastasize to bone where we have pain and fractures. And most of the time, this lung cancer is going to cause lytic lesions, so it's going to erode the bones away. Then we have hypercalcemia, which is due to a number of reasons, which could be due to production of parathyroid releasing hormone, which is a paraneoplastic thing, or it can be due to the breakdown of these bones too. Then we have the liver, where we shall have things like hepatomegaly and right upper quadrant pain, as well as the adrenals. Then the paraneoplastic syndrome, which I'm going to explain, as well as a mnemonic that we can use to remember the common features of lung cancer. That is lung cancer itself. So the L is for the local invasions or the local symptoms, which are the respiratory symptoms. The U is for unresolved infections like pneumonia. We have nerve involvement, that is the recurrent laryngeal nerve. We can have the phrenic nerve palsy. Then we have general symptoms like weight loss, the things. We can have central obstruction, that is superior vena cava syndrome. Apical or the Pancoast tumor, which is the Pancoast syndrome. We can have neurological metastasis, which is metastasis to the brain, that is the headaches and seizures. Then when we have calcium abnormalities, and calcium should be remembered that there are also other endocrine abnormalities. And then we have regional invasion. Then when we look at the paraneoplastic syndrome, so paraneoplastic syndrome is a set of systemic signs and symptoms caused by cancer, but they are known due to the direct invasion, metastasis, or treatment effects. So the tumor is there, it's in the lungs, but we're having manifestations that are not in any way related to anything that the tumor is doing, not due to the pressure or the invasion of the tumor, not due to the metastasis of the tumor, and not due to the treatment, but rather due to substances that are produced by the tumor. E.g., we have hormones, cytokines, and immune reactivity. So the mechanisms of paraneoplasticism, these patients is going to be, we have ectopic hormones, whereby the tumor has neuroendocrine cells. The neuroendocrine cells start producing hormones like ACTH, ADH, and parathyroid hormone releasing hormone. So we have ACTH when it's produced, going to go to the adrenals, cause release of cortisol, and we have hypercortisolisms, which will be preceded by a Cushing's syndrome. When you have ADH, we are going to have antidiuretic hormone being released. Antidiuretic hormone is going to go and act on the kidney. We are going to have water retention. We have water retention. Hyponatremia is going to come in. So a patient will present with symptoms of hyponatremia. Then we have parathyroid hormone releasing peptide, and this is going to cause, it's going to act as parathyroid hormone. It's going to cause release of parathyroid hormone, and this is going to lead to hypercalcemia. Then when we look at immunotherapy, sometimes these tumors produce antigens or antibodies that are not, that attack the normal tissues. So we find it's producing a tumor, an antigen. The antigen is detected by an antibody, and it realizes these are foreign. But again, these antigens kind of resemble the ones that are in other places in the body, like the nervous system, which the body didn't know about before. So it realizes we have these new antigens that's attacking them, and we have that thing. For example, when you look at the Lambert-Eaton myasthenic syndrome, that can come when we have this paraneoplastic syndrome. Then we have cytokines and growth factors, and this also can cause different effects. For example, when we have release of growth factors, we might have hypertrophic osteoarthropathy, which will present as that finger clubbing. So commonly, these are the common paraneoplastic syndromes that we have. When we have small cell lung cancer, we have neuroendocrine origin. When it comes to the cells where it comes from, that is going to secrete hormone. The squamous cell carcinoma is associated with parathyroid hormone releasing peptide, and this one is going to cause hypercalcemia. Then the adenocarcinoma sometimes associated with hypertrophic osteoarthropathy. and stressor syndrome, which is basically migratory thrombophlebitis. So the clinical importance of paraneoplastic syndrome, and this is a very important thing to understand when it comes to lung cancer, is that sometimes the only or the first clue that we have that we get when we are having this cancer, even before the diagnosis is made, is that we have a paraneoplastic syndrome, and it may mimic a primary endocrine immunologic disease. For example, if you're having ACTH secretion and then you develop the Cushingoid features, one may assume that it's a primary adeno problem or the pituitary, but when actually it's now an ectopic ACTH, which is coming from this lung cancer. And one way to differentiate between ACTH and that is ectopic and one that is from the pituitary is just when you look at the value or the assay, when you do an assay of ACTH and you have values greater than 200, most likely it is an ectopic source. Also, if you don't have suppression of this ACTH with high dose dexamethasone, then we can suspect still that this is coming from an ectopic source, because when you look at when you have ACTH from pituitary adenoma and you give a high dose of dexamethasone, there's going to be some suppression at about greater than 50%. And when you give a low dose, it should be noted that when you give a low dose, whether the ACTH is coming from the pituitary or an ectopic source, there will be no difference, there will be no suppression. So only high dose can help us to differentiate the two of high dose of dexamethasone. So sometimes this paraneoplastic syndrome is going to resolve or improve when we treat the tumor. And when you have a recurrence of the paraneoplastic syndrome, it may be a signal actually that we are having a tumor relapse. So we'll go to one approach with the patient with lung cancer. So the most important thing, or the important things to do is a history taking, where smoking, exposures, cough, hemoptysis, dyspnea, and weight loss have to be assessed for. Then we do examinations where you may see things like clubbing, lymphadenopathy, and superior vena cava open cost signs. Those signs of the blockade of those vessels that are returning blood to the superior vena cava. Then when you do the labs, you may do a CBC, LFTs, RFTs, calcium, electrolytes. These ones are going to depend on how these paraneoplastic syndromes, maybe if you have things like pneumonia going on, the CBC may change. When you do a chest X-ray, and this one is the initial investigation, most of the time you may see just a mass or a nodule, you may see a lung collapse, you may see a consolidation, or you may see a pleural effusion. These are the commonly seen manifestations. And then when you investigate, the gold standard for investigating lung cancer is going to be the contrast-enhanced CT of the chest. And this one is going to characterize the tumor. So we shall see the tumor size. And mostly, lung cancer tumors are greater than 3 centimeters. The margins are going to be irregular. Sometimes they are spiculated. And then we have formation of cavities. We can have, when you look at the mediastinum, we can see lymph nodes there. The hilar lymph nodes are enlarged. And as we go on, then we have chest wall involvement in some cases. Then we have a central lesion. When you have a central lesion on CT, or you can do a bronchoscopy. And then when we do the bronchoscopy, we go ahead and do the biopsy. Then if you have a peripheral lesion, of course, you may not be able to reach it through a bronchoscopy. Then we can do a CT-guided biopsy. Then others can do sputum cytology, pleural fluid cytology, and surgical biopsy. Then we do the histology and the molecular testing. And this is very, very important, because when you do histology, you're going to tell, is this a small cell lung cancer or is it a non-small cell lung cancer? And then when you do the molecular testing, you're testing for the genes that may be responsible for driving this cancer. So we have the EGFR gene that has been implicated, the ALK gene, the ROS1, and the PDL1. And these are important because we have drugs that target these specific genes or these specific aberrations and help us to improve the survival of this cancer. Then we can do a chest CT or abdominal CT if we have liver adenocarcinoma metastasis. Then we can do a PET CT. Now the PET CT is going to show us the nodes, the distant metastasis by using the metabolic activity. So the principle behind the PET is that when we look at these tumors, they are good at taking up glucose. So when we give them our fluorodeoxycholate glucose, the one that is radio-labeled, with the one that is labeled that way, and we give it a time, these tumors are going to take up more of this. And when you do the PET scan, you will be able to actually see these areas where the tumors are, as well as the metastasis, the multiple metastasis. Then we can do a brain MRI, and this one is routine when you have small cell lung cancer. Or if you have symptomatic non-small cell lung cancer, then we can do a bone scan when you have bone pain or elevated ALP. And when you have mediastinal nodes, you can do an endobronchial ultrasound and mediastinoscopy if needed. We can do pulmonary function tests. If we are going to plan to do a surgery, you want to make sure that the patient has good pulmonary function, lung function, and the echocardiography or ECG for cardiac assessment. They may have to do the labs for the paraneoplastic syndrome. Remember, you may have syndrome of inappropriate ADH expression, Cushing's, and hypercalcemia. Then we have the MDT discussion, multidisciplinary team discussion, where we involve surgery, chemotherapy. Then we have the multi-drug therapy discussion, where we discuss we are going to do surgery. That is especially in non-small cell lung cancer, chemotherapy, radiotherapy, then targeted therapy. For example, if you have these genes like EGFR, ALK, ROS1, PDL1, and then palliative care. So sometimes you have what we call secondary lung cancer. This is lung cancer due to lesions that are not originated from the lungs. And these common primary sites for secondary lung cancer or for mets to the lungs is going to be the breast, the colon or rectum, kidney. Melanomas are also going to go to the lungs, sarcomas, and head and neck. And the pathway of spread is mostly hematogenous, lymphatic, or direct invasion. And clinical features is often asymptomatic, may have cough, hemoptysis, dyspnea, or chest pain. And the imaging features is that most of the time when we have multiple round, well-circumcised nodules, which we call the cannonballs, they are going to be because of these mets to the lungs. Then the diagnosis is going to be history of a primary malignant. Someone tells you I had maybe maybe someone tells you I had breast cancer, I had a melanoma or a colon cancer, and now they are presenting with these cannonballs. Then you can tell. And then when you do histology, you're going to identify that the tissue may resemble the tissue of origin. Then the management is going to be systemic therapy targeting the primary tumor. We target the primary tumor. That is, if it's colon cancer, we target the colon cancer. And then symptoms control. Sometimes surgery may be done, which is called the metastasectomy, where they remove the metastasis with surgery. Then when you go to the last part of this video, that is the management principles. We want to confirm the diagnosis and staging. We want to do a histology where we differentiate our small cell lung cancer from the non-small cell lung cancer. Then if we have non-small cell lung cancer, that is, if it's in stage 1 and 2, we may do surgery, and the lobectomy is preferred. And then adjuvant chemotherapy if there is high risk. Then stage 3, where things are now advancing, we may do the multimodal therapy, where you want to give chemoradiotherapy on top of chemotherapy. And then in suggested cases, we may do with surgery after the neoadjuvant chemotherapy. So you may give chemotherapy and radiotherapy before, then the tumor shrinks, and then you do the surgery. Then the non-small cell lung cancer, if we are in stage 4, mostly we go for systemic therapy, and that is targeted therapy using the EGFR, ALK, ROS1, BRAF, and immunotherapy. Chemotherapy can be done if there is no actionable mutations. That is the targeted therapy, and then we do palliative care for symptoms. Then if we have the small cell lung cancer in limited stage, we can combine chemotherapy, radiotherapy, and prophylactic cranial irradiation. Then if it is extensive, we do systemic chemotherapy, immunotherapy, and palliative radiotherapy for symptomatic metastasis. Then when we have to do the supportive management, where you give oxygen analgesia, antiemetics, nutrition, we manage complications, and then we do the follow-up. of the treatment, whereby we monitor for recurrence or metastasis and surveillance every 3 to 6 months for the first 2 years, and then annually thereafter. So this is as a diagram showing us some of the ways how the surgeries can be done. So we can have a wedge resection whereby a tumor is here and we just cut off a wedge section of that. We can do a segmentectomy where we remove a segment of a lobe. Then we can do a lobectomy where you remove a whole lobe. So we have come to the end of this video. I hope you enjoyed it. I hope you understood a lot about lung cancer. Tell me something that you find unclear or something you want me to explain in the comment section. You can also tell me what you have not understood. But I think I've covered most of the basic information, or I've given a good background of lung cancer. Till we meet again, my name is Benjamin. Have a nice day.